Welcome everyone to our TIF Talk Tuesday. I'm happy to have Dr. Eli Penn here with me today. So thank you for being here, Dr. Penn. Dr. Penn is from Navicent Gastroenterology Center. He's the Associate Professor of Medicine at Mercer University, and he's located in Macon, Georgia. So welcome, Dr. Penn, and thank you for being here.
Thanks for having me.
You're welcome. I'm Andrea Millers, and I'm with Endogastric Solutions. Again, this will be a nice Q&A. Dr. Penn will kind of discuss GERD and also the TIF procedure, and then we'll go into a Q&A. So if you have any questions throughout this talk, please feel free to ask them, and we'll try to get to as many questions as possible. If we don't get to all of the questions, don't worry. We'll be able to get them. We're doing TIF Talks every Tuesday, so if they don't get answered today, we will answer them at the next TIF Talk. But for now, we've got Dr. Penn, and you got a really cool background you got there. I'll let you talk a little bit about what GERD is, and maybe you can discuss the picture and what the TIF procedure is. Awesome.
Yeah, so GERD is, I'll start with what GERD is not, and that is excess acid production by the stomach. I always find it amazing how many patients think they have too much acid and use that quote. And that is not the problem. They're supposed to be acid in our stomachs, and it turns out it has very important purposes. The way we've been treating GERD since 1989 is by shutting off acid production, so that in patients with an abnormal anatomy of the lower esophageal sphincter, whatever comes up into their esophagus doesn't burn them and cause what we know as heartburn. GERD is actually a structural disease where gradual deterioration of the valve between our stomach and our esophagus or food pipe leads to reflux of stomach contents into the esophagus. And that is not that is the part that's abnormal, and the reason that people have symptoms because of that structural abnormality, which happens to be very common. People often ask me after an endoscopy, why do I have a hiatal hernia? Did I do something to get that? And we don't really know the answer, but it is extremely common. So that when we get certainly into adulthood, a high percentage of patients have some change in that valve, if not a true herniation of the stomach up into the chest. And it's that structural change that leads to the occurrence of reflux. And reflux is what causes all the uncomfortable symptoms associated with GERD. It's not the production of acid or overproduction like many people think. It's actually a structural disease. Now, in the late 1950s, Dr. Nissen, a famous surgeon, came up with a procedure that would address that structural problem by restoring the stomach to the abdomen and stopping reflux from occurring. And by the 70s, that was the mainstay of therapy for people with severe reflux.
Right.
Many millions of procedures done. So, and then in 1989, the first PPI, which is a proton pump inhibitor, came to market called omeprazole. We all know as Prilosec, and that changed things forever. It was so effective to trick the stomach into not making acid that a majority of patients had much relief of symptoms and better quality of life. And we sort of made a decision, either consciously or unconsciously, to treat reflux sufferers with this medicine rather than addressing the structural problem.
Right. So why don't you discuss what TIF is and how the procedure actually works?
So So really, I should continue on with the historical treatment of GERD then, because
Sure.
it was over time there were a minority of docs who didn't like the idea of just tricking the stomach and not making acid, and who assumed that there might be some untoward consequences of that, and who continued to work in the background on ways to address this hernia, or if not a true hernia, this failure of the valve to work mechanically. And there are numerous devices, including the device we use in TIF called the Esophagus device, that has been renewed and redeveloped, re-engineered, until we finally have what we think is a much better way to treat to GERD than chronic daily acid suppression. And we can go into that. But in the TIF procedure, unlike the traditional surgery that Dr. Nissen came up with, we use an endoscopic device here behind me. And I don't know if any of you can see that. I'm going to pretend to point to it.
Yeah.
This is a device that fits on the endoscope. And when we go down through the dysfunctional lower esophageal sphincter, we're able to grasp the valve and to push it down, or we call reduce it, get it back beneath the diaphragm where the pressure is high, and that's what is part of what keeps acid from coming up. And then we're able to anchor it by using this device to reconnect the stomach and esophagus wall below the diaphragm. And that serves the purpose of stabilizing the repaired valve beneath the diaphragm in a similar way that the Nissen fundoplication, they surgically connect the stomach around the esophagus back to itself. So it's a similar concept, but a much less aggressive bolster, if you will, with far fewer side effects. So it mimics normal human physiology and anatomy in a way that the Nissen procedure did not. So while for many, many years, certainly all through my training and a lot of my colleagues' training, we did not want to send our patients for surgery for their GERD because of the potential complications, the fact that it can come undone after, a 20% rate after 5 years and be very hard to repair then. We just prefer to keep them on medicine. But now that we have devices like the TIF, where the patient doesn't actually have to have an incision, it really changes the dynamic of GERD treatment. And it should, because we, during this time when we were developing the Esophagus device and improving upon it, we're starting to learn more and more about the consequences of long-term acid suppression. They're not good, and the data is mounting that we need that acid. It's there for a reason. So a lot of us are starting to think differently about the true mechanism of GERD rather than just tricking the body into not making acid.
Yeah, thank you. That's a very great explanation of what GERD is and what TIF can do today. We already have some questions, so I'm going to read some of the questions that we've gotten from Facebook thus far. We have Frank Gleason, I believe. Yep. He's asking, how suitable is TIF for someone with GERD and Barrett's?
It's very suitable. So by definition, someone with Barrett's has pathologic GERD, so dangerous levels of GERD. And there are a couple criteria that prove that without any further testing. Barrett's forms and progresses to dysplasia and cancer in the setting of low pH in the esophagus. So it only makes sense to stop that underlying cause. And the best way to stop it is to fix the valve, make the valve function again. Sometimes patients who have that repair, the Barrett's will regress spontaneously, maybe up to 20%. In other patients, it stays the same, but it markedly reduces the risk of cancer in a Barrett's patient to actually have a structural fix to that valve.
Right. Okay. Great. Thank you. Mandy Cruz is asking, what is the best measure to see if there is structural issue, and which specific types of structural issues are you looking for?
That's a great question. So when I was in training in gastroenterology, we honestly we weren't taught to pay enough attention to the valve in what we call retroflex view. So again, in the picture, this device is coming through the valve. The scope looks forward, so we quickly pass the valve and look at the rest of the stomach. One step, a maneuver we make, is we turn the scope around backwards to inspect that valve, and we would typically do it for a few seconds. Nowadays, now that I do TIF and think about reflux from a mechanical standpoint, I spend a lot of time looking at that valve and watching my patient while they breathe. I want to see just how much stomach moves above the diaphragm away from me while they're breathing in and out to size up the vertical height of the hernia or the vertical defect in the valve, if you will. I also want to get a sense of the width of the defect. In other words, we call it hill grade, but how many centimeters wide is a defect? Does it allow my scope to go through and stay closed, or could I fit 3 scopes in there, or 4 or 5? Right. Those are very important dimensions to see what mechanical fix is going to be best for my patient. So those are the sort of the things I want to know. I also want to know, do they have Barrett's esophagus? But the main change for me has been a careful inspection of the valve. And honestly, I have to credit Dr. Murray, who gave our last TIF talk, to that piece of advice.
Great. Wow. Thank you. Frank said, thank you for the very clear answer. The next question is from Rima Haddinen. If TIF did not work, can we do after TIF Nissen? Okay, so if TIF did not work after a Nissen, can they do a Nissen? Wait, hold on, let me read this carefully. If TIF did not work, can we do after TIF a Nissen fundoplication? And another question, is it reversible?
Yeah.
Go ahead. I'll let you answer.
It's a very good question. So one of the strong suits of the TIF procedure is it's so minimally invasive to do, but it's also minimally invasive to revise if needed, or to convert. So it would not get in your way of doing a laparoscopic diaphragm repair, which is integral to repair in patients with large hiatal hernia. So just to give you an example, if I do my good inspection and the hernia is actually larger than it appeared, and that even though the TIF wrap is in perfect position, the diaphragm just got to be repaired to get the patient good relief. The surgeon can easily go in without affecting the TIF and tighten up the diaphragm, because the diaphragm has to have the hole in it that allows the food pipe to connect to the stomach has to stretch or rip to allow the stomach to actually come into the chest and cause a hernia. In small hernias, that's not an issue, but in larger hernias, we repair that diaphragm laparoscopically at the same time that we do the TIF endoscopically. And in my case, I work together closely with my general surgeons, and we both have a hand in it. In Dr. Murray's case, he is a general surgeon, and so for patients with large hernias, he'll do both parts. So that's one variety. If the TIF for some reason was not enough, or there was recurrence of reflux, 7 years after the procedure. The first step would be to evaluate why, and then it could be that simple revision with the TIF device, another endoscopy, could fix everything. If there was herniation and we felt that the diaphragm needed to be tightened, that can be done laparoscopically without having to undo the TIF. Which I haven't seen yet, if the TIF just fell apart for some reason. Pardon me.
No problem.
Turn that off. If the TIF fell apart for some reason, then it would be very easy for the general surgeon to take it down and fix the diaphragm and do another intervention if he saw fit. Here at Navicent, the surgeons I work with, especially in people who have imperfect swallowing function, which most patients don't even realize, we think that the combination of curl repair and TIF may be the best treatment yet for reflux in people with hernias larger than 2 centimeters. So I can't think of a reason to convert somebody to a Nissen. I won't talk negatively about the Nissen because it's a very common operation, and a lot of people that is their tool. That's what they know how to do. However, I will say that there are better ways now. So they're with less side effects.
Perfect. Wonderful. Thank you for that. Frank has another question. What are the latest published papers on the results of TIF?
So there are several, and let's see, am I able to post these or no? Can't share my screen. I'm going to just list a few if you want to take notes. Peter Janu and Dr. Mavrelis published an article looking at the quality of life scores after a combination diaphragm repair and TIF, and that is in surgical innovations in 2019. Yep. There is a 5-year durability study from Dr. Stefanidis in surgical endoscopy, 2015. What else? Let's see.
There's the Tempo trial, 5-year.
Trial. It was a huge one.
That was in Surgical Innovations 2018 as well. And we can post those for our Facebook users if they want to look at those.
And Dr. Ide's study in 2019.
Yes, and Dr. Ide, that's probably the latest one that we have available right now, I believe. So, so thank you for sharing those. The next question is, would you recommend TIF for a 2 to 3 centimeter hiatal hernia? I'm 38 and in good health and weight. Recent surgeon told me TIF is for old people and Nissen is the gold standard. I don't know that to be true. Can you chime in?
Well, no, I laugh a little bit, but honestly, we all have gone through a transition in our thoughts about reflux. So it's not a wrong thought on the surgeon's part, but I don't agree that TIF is for old people. One of my biggest success stories was a 27-year-old man who was stuck on Dexilant, double dose every day for 3 years, and was still having trouble. And his insurance company didn't actually cover the TIF. He came up with the money himself, and that was 4.5 years ago, and he has not had reflux since. In fact, if I call to check on him, I can't get him to answer the phone. He doesn't want anything to do with doctors. I mean, he's done extremely well. So TIF is a great early option, because what we think happens is the structural changes in the valve start early and progress as we age. So it's such a great opportunity to find somebody when they're first beginning to have reflux and have minimal change in the valve, to intervene with the minimum necessary tool, which is the TIF. And to harken back to the last question about research, there was a excellent study by Dr. DeMeester, very well known in the surgical literature, that showed that over 60% of patients with GERD who have to take PPIs, when we do an endoscopy, have little or no change in the valve. So those patients wouldn't even be offered a surgery. There's nothing to fix in the surgeon's eyes. They have valve dysfunction and slight change, but they're not candidates for a Nissen. Now, to the other point for that question is, yes, Nissen was the gold standard, certainly in the 70s, 80s, and in some places still today, because that's what people were taught in training. But it went away for a reason, not just because PPIs were so much easier, but patients after Nissen, because of the way they wrap the entire stomach around the back of the esophagus and sew it back to itself posteriorly, a lot of patients have swallowing trouble afterward. I've had numerous patients I've had to try to dilate to get them so they could swallow again, even though you can see down as if there's no obstruction, they just can't swallow. The other things patients with Nissen complain of is gas bloat. So people who have GERD subconsciously swallow air all day, and that's the body's reflex to try to get acid out of the esophagus. And if you suddenly block that valve in such a robust way like the Nissen, they feel like their stomach's going to explode because they're swallowing air, but it won't go anywhere.
Right.
And they're extremely uncomfortable. Finally, if that Nissen, if the person who asked the question had the Nissen and she's one of the 20% of patients where the Nissen fails in 5 years, there are not many surgeons, including the one that did the original procedure, who are going to want to do a revision. And the reason is it's much more dangerous to revise a failed Nissen and much less likely to work. So there are some trappings with the Nissen fundoplication, and I'm not sure that I'm pretty sure that PPIs are not the answer. But now that we have tools like the TIF, it's time to revisit the mechanics of GERD and try to focus on that. I think that the Nissen essentially is anatomical overkill for GERD. We make the body we make that valve supranormal rather than normal, and with some consequences.
So you did discuss a little bit about the Nissen, taking that down. The next question is TIF reversible. So maybe you can talk a little bit about that.
So I can't think of any reason that anybody would reverse a TIF, but if you wanted to, yes, it's reversible. So we put between 28 and 30 fasteners to join the stomach and esophagus to recreate the valve below the diaphragm, and those fasteners can be removed. But I can't think of an indication. So, unlike the Nissen, except for the first week after the procedure when there's some swelling, there's never been a case of people with swallowing trouble or I'm trying to think of another consequence, or gas bloat that's so severe that they just want it taken down. But the people who are miserable enough with reflux that they really want something done and they don't want to take medicines for life, they do so well with the TIF. I've never been asked, can this be taken down? So it's a lot like the surgeons would say the same thing probably, that there's not many people asked to have a surgery undone.
Right. And based on, all of the clinical studies, there's 81% of them are significantly improved quality of life scores. So to your point, a lot of satisfaction with the TIF procedure. So Frank, that asked a question earlier, was asking, what's the typical non-insurance cost for the TIF in the U.S.? I know obviously depending on where someone's located, it will be different, but maybe you can answer for your location.
Well, at the location where I was when I did the patient I talked about a minute ago, I believe it was about $7,000.
Okay.
And but what we're seeing is rapidly improving insurance coverage around the country, and that's a good thing, because there are some very big name insurance companies who it's sort of widely known, tend to call every important innovative test in GI experimental, even though they're all considered standard of care. Slowly they're seeing the light and seeing the benefit to their patients. From an insurance company's perspective, they're saving money on these very expensive drugs. In 2013, PPIs brought in $60 billion a year. So the pharmaceutical industry for reflux has a very heavy influence on politics, and it trickles down into medicine. So anybody who watches TV knows the commercials for reflux medicines are pretty common. So they have a lot of power from the money they've made since 1989 when Prilosec came out.
Well, let's talk about that a little bit. The FDA just took Zantac off the market, right? Do you want to talk a little bit about that and how that affects maybe people that are taking it, or what they should do? Talk to their physician, maybe discuss that a little bit.
So it's unfortunate. Zantac was taken off the market due to a contamination issue, and unlike the PPIs, it was a weaker H2 blocker, which has not been associated with some of the problems we see with the potent acid suppression that PPIs induce. The cousin of Zantac, Pepcid, is still on the market, and in a patient who's not a candidate for any mechanical intervention, I try hard to get them on a safer medicine like Pepcid, or in the past, Zantac. The concerns about PPIs have been, like a lot of things in medicine, sort of hard to prove the disease associations, because we start with observational studies. We look at large numbers of people over time with common conditions, and we try to draw a correlation. And that'll come with heavy criticism anytime it starts. But we started seeing that there may be an increased incidence of heart disease and stroke and kidney disease in patients who took PPI. And at first, this was started in 2016. A lot of us thought, well, this doesn't make any sense. These diseases are so different. How could they all be related to acid suppression? We knew that people were more likely to have bone density problems and osteoporosis, and we just kind of accepted that. But we didn't know about these vascular problems. And then in 2017, there was a paper describing the fact that there are receptors for Nexium in the stomach, and there are receptors in blood vessels. And when PPIs bind these receptors in blood vessels, they cause cell death in the cells that line our blood vessels. Well, that at least could be a common mechanism between kidney disease, heart disease, stroke. But it's just a theory. We don't have any randomized controlled data. So the people who are very protective of the industry launched studies to look at PPI safety. And in 2019, the first randomized control trial, which is very important to those of us in medical research, in accurately demonstrating a cause and effect, they showed that over 3 or 4 years, there was no difference in any of these diseases in people who took PPIs. And so that seemed to reassure people. My comment to that was, you can't show a difference in people who smoke and don't smoke over 3 or 4 years. It's 15 years we need to look at. So it's inconclusive, but I can tell you I've seen patients with infection. A great example was a mother in a family of 6 who was hospitalized for salmonella, so a very bad gastroenteritis, food poisoning.
Right.
She made the same chicken meal for her whole family, and it was undercooked, but the only one who got sick was her. And she had been started on Nexium 6 weeks before. Coincidence, maybe, but I doubt it. So we know that people are more likely to get infections when they don't sterilize their food with that stomach acid. We're just slow to react, and as people learn about and have the TIF procedure and innovation continues, I think we'll look back on this last 15 to 20 years and say, what were we thinking? The surgeons were right. It's a mechanical disease. We just didn't have the right mechanical treatment until now.
Nice. Well said. Thank you. I did have another question that came up asking, I know you answered the question for non-insurance costs for TIF, but what is the usual cost for a patient that does have insurance?
Well, usually just the copay, so the whatever your insurance company holds you responsible for when you have an elective procedure. That's usually it.
Thank you. So we have another question here. Let's see. Sorry. I'm trying to find all the questions that are coming in. How do you decide if a patient is a candidate for the TIF procedure?
So if someone like one of the members of the audience who had Barrett's esophagus, I presume, and a history of reflux, typical symptoms, not much workup is needed because people have Barrett's or who have had a stricture that needed to be stretched, or who have what we call grade C esophagitis or worse. So bad inflammation on endoscopy. Do not need any further testing to prove that their reflux is severe enough. Many of us doing TIF have followed after the surgeons doing Nissen and do a manometry, which is a test that measures your ability to swallow normally. Surprisingly, imperfect swallowing or peristalsis in esophagus is more common than we know. Patients will not recognize they have to double or triple swallow. And for the Nissen or the Lynx procedure, that's a real problem. So the manometry will pick up on those patients and will realize that if we do a Nissen or a Lynx, that they're going to have trouble swallowing to the point they may have food impactions and have to have it manually removed. There are some people doing the TIF who have stopped doing the manometry just for the fact that even in people with severe swallowing disorders, the TIF does not make them worse. Mm-hmm. Even in people with zero peristalsis, achalasia patients will do TIF after we treat their achalasia. So that makes some sense to me that it's an extra step to do a manometry and a rather uncomfortable test with a catheter down your esophagus, and you have to swallow to measure the pressures. It may not be necessary in TIF because they're really, even if it's abnormal, they're really, I can't think of a reason that it would prevent somebody from having a TIF. But between the manometry and in patients without those obvious signs of pathologic reflux, no Barrett's, no history of stricture, and no esophagitis, we'll leave a tiny little microchip that suctions to the wall of the esophagus, and it hangs there for a few days and sends signals to a receiver you wear on your belt, and it'll tell us how often acid gets into the esophagus and how low the pH gets over about 48 hours. When nobody's looking, we want to know, is reflux occurring? Right. And furthermore, you'll have a little button and your doctor will tell you to press it when you have your symptoms, so we can correlate your symptoms with reflux. That's particularly important in patients who've had heartburn for a long time and then the pain goes away. I have a lot of patients who just say, I cough all the time. I'm hoarse every morning. I don't have heartburn. I haven't had it for 20 years. It used to be bad. And we think that they sort of have a burnout of their esophageal pain sensory, and their only remaining symptoms are this chronic cough or new onset asthma at age 45, a diagnosis of COPD even though they never smoked. These are the people that I like to demonstrate, yes, there is reflux occurring, and boy, every time I cough, it was because of a reflux event. So that's very, very helpful. And that can be done at the time of the initial endoscopy to look at the valve. So we try to consolidate those tests into as few procedures as possible.
Perfect. Wow, thank you so much. So we have a couple more questions, but maybe two more questions, and then we will save the rest of the questions for next time. But we've got Christy who is asking, hi, Dr. Penn, would TIF be a possibility after POEM?
Oh, absolutely. There's several centers looking at that, and even more empirically doing it. The 30% of patients after POEM will have pretty bad reflux. And that's just the nature of the procedure. So not everybody needs a TIF after POEM, but in those 30%, it's ideal. Certainly, if you have had the endoscopic treatment for achalasia, it makes a lot of sense to have an endoscopic treatment for any GERD related to it. I believe it's at Hopkins. They are doing a simultaneous POEM and TIF, which is very similar to the old surgical treatment for achalasia, which is a Heller myotomy, which involves a partial wrap. Partial because we don't want to make it too hard for somebody to swallow with poor motility, which is very much a guesstimate. So remember, I said that with TIF, nobody with a swallowing problem gets worse. Never been reported. Over 25,000 cases now, never happened. Whereas, and that's even achalasia patients. So whereas people after a surgical wrap, because it's not normal anatomy, often have dysphagia, and certainly people with achalasia will have trouble getting things through a wrap, a non-physiologic wrap. Right. So it's I think it's a big improvement on the old treatment for post-achalasia reflux and on the empiric wrap that was done with the Heller myotomy.
Perfect. Thank you. Well, this will be the last question for the night from Mandira. She's asking, hi, Dr. Penn, does it affect the area where the TIF was performed after becoming pregnant? So
after becoming pregnant. Oh, so if you have a TIF and then get pregnant.
Right. Would it?
It shouldn't. Now, no, I can't think of any way. Certainly increased intra-abdominal pressure during pregnancy, but after 8 weeks after your TIF, there's really no restrictions. So the 28 to 30 fasteners that we place to rebuild the valve really do the heavy lifting. In other words, they hold things together for about 2 weeks. At that point, the tissues of the esophagus and stomach begin to grow together, and then they scar together. And by 8 weeks, those fasteners are completely obsolete. So you have a new anatomy and fusion has occurred. So unless you had the TIF in the last few weeks of pregnancy, which nobody would do, I can't imagine that it would have any impact on the effectiveness of your TIF afterward.
Perfect. Okay, one more question. What is the post-op diet for TIF after TIF?
So if there is any downside to the TIF, and it's not really terrible, but people are on liquids for several weeks. So it's a little variable from institution to institution. I like my patients to stay on clear liquids for 3 days. And then I advance them to full liquids. And then for 6 weeks, it's very important that you don't eat anything that could become a ball before it hits your stomach and get lodged above the TIF, which means, no steak, no, I would say no macaroni. We have more intricate lists about what to avoid, but the idea is until 8 weeks has passed, or certainly 6 weeks when it comes to diet, we are not stable for the long haul, not necessarily. So, and we don't want people with a fresh TIF to swallow something that gets hung up and then as it works through, tear a few of those fasteners out, because we don't know, but that may be a person 7 years later who has recurrence and needs a few more fasteners.
Right.
But to back up and readdress that question from earlier, this TIFs can be revised with the TIF device, the esophagus device, should there be any problem with recurrence. Hernias are constantly trying to recur, and that is a strong suit of this procedure. So in the same way, we can use the esophagus device to repair failed Nissens, which has made a lot of older people who've had failure very happy because they couldn't find a surgeon to help them with the reflux, having already had the Nissen. And we come in with the esophagus device, and lo and behold, we repair their surgery with an endoscopic device. And, I have some very memorable experiences with that. Usually after TIF, the people with non-heartburn type symptoms are better that day. They stop coughing, their voice clears up, and it's very rewarding for me to offer something that can give an instant relief to people's long-standing symptoms.
Yeah, thank you. Okay, I feel like this question needs to be answered. So I have another question. Maggie's asking, have there been complications with this surgery?
There are some complications. The most serious one would be esophageal perforation. That's extremely rare. So just for comparison's sake, TIF is safer than colonoscopy, which also has a chance of perforation. And certainly we recommend colonoscopy for everybody for very good reason. But complications are rare, and they usually can be addressed during the procedure. Again, the worst thing is if the esophagus were to tear.
Right. Thank you. I thought they would probably want that answered before we left off today. So everybody that's on Facebook and watching today are very, they're thanking you for being on here. They said, excellent talk so far, Dr. Penn, very informative and confident point of view from Frank. And also another, Lanil, said he's very knowledgeable in his field. Thank you very much for your info, Dr. Penn. So on that note, I'm going to thank you again for being here and for sharing your perspective on the TIF procedure and GERD with all of our Facebook users. We will follow up with some posts on the clinical papers that they were asking about. But also, I just wanted to let everybody know that if you are looking for a surgeon in your area, if you're in Macon, Georgia, Dr. Eli Penn is there. But you can go to gerdhelp.com. There's a lot of information on there as well about diet, post-op, what to expect during the procedure. And then there's also a physician finder on our gerdhelp.com webpage. So you can put in your zip code and you'll be able to find a TIF trained physician in your area. In addition to that, we do have a new YouTube channel that we post many of these videos, these live chats. We also have some videos, some patient testimonials that you can watch and listen as well. So you can join that. It's just GERD Help channel. So again, Dr. Penn, I can't thank you enough for being here and joining us today and sharing your expertise. And we will have another TIF Talk, like I said, every Tuesday. So TIF Talk Tuesdays. It's Cinco de Mayo today too, so happy Cinco de Mayo. Dr. Penn, any final thoughts that you wanted to share with everybody?
No, only that if you're getting your PPI from your primary physician, ask questions. Ask about long-term safety because the data is changing all the time. Ask about the TIF procedure, what your options are, particularly those of you who are looking at 40, 50 years of being on the medicine. Right. Imagine what may come out. So it's very important to be engaged with your prescribing physician about whether there are any implications.
Perfect. Well, thank you very much again, Dr. Penn, and thank you everybody for joining us tonight. We hope you have a great rest of your day. Thank you.
Thanks.